responses over the last few webinars that we have had in the last year. And so this time we thought that we will also do something about cervical cancer. So Hagagi, we have kept a few topics in cervical cancer, which are kind of the in thing for tonight. So we have very eminent speakers, and I'm sure all of you would have a great evening today. So yeah, over to you, Prerna. Yeah, before that, thank you so much, President Ma'am, Rajshri Madam, Shobha Guri Madam, and all the Kasuga team for having given this opportunity to us. So being the chairperson of Gynae Oncology Committee, of course, we've been doing quite a decent amount of work, but since we are limited with very few cancers, so we are coming out with these kind of the subtle but very important topics. So hope all of you have a good time. Over to you, Prerna, for the formal introduction and yeah.
We normally start with a prayer song.
Yeah, Mr. Arun will play it. Sorry. Mr. Arun? Yeah. Okay, Prerna?
Yeah, you can proceed, Rupesh. We are actually quite late. Hello.
Yeah, sorry, man. So yeah, today, as already we told, like today will be a day wherein we are trying to look at the paradigm shifts in terms of cervical cancer. What's new? So we have the preventive aspects. The first speaker is Dr. Veena. Dr. Veena Ranjan, ನಮ್ಮ ಅಪ್ಪಟ ಕನ್ನಡತಿ. But yeah, she's been there in JIPMA for a long time, and she's the course director for MCH Gynecological Oncological Program there. Very proud to have her. I have actually been wanting to have her for our webinars in Kasoga since a long time. And ಈ ಸಲ ಒಂದು ಸೌಭಾಗ್ಯ ಸಿಕ್ತು ಅಂತ ಹೇಳಬೇಕು. I know despite her very busy schedule and a lot of other academic commitments, she has been here today. So yeah, Dr. Prerna, could you please formally introduce Dr. Veena quickly, and so that
can I just welcome everybody, Rupesh, on behalf of your Kasoga.
Please, madam.
So a very hearty welcome to all the listeners. There will be a very brief message from me as well as by the President, Dr. Rajeshri Paladi. So Rupesh, I really richly congratulate you for bringing in yet another very, very hot and vibrant and very interesting subject of cancer cervix. We all know that early cervical disease and its detection and management is the forte of the gynecologist, and we can still prevent invasive cancer if we do a good job of that. And I am really appreciative that you got the very, very best faculty to deliberate on the subjects. Veena from Zipmar and our own revered Dr. Sundari, who has done so much of original research and work for CIN, colposcopy, and treatment of early cervical cancer. I really heartily welcome you, Sundari, to this forum, and also Dr. Vinay Babu as a consultant, where a multimodal therapy and managing treatment sequelae will be discussed, because I think these are cases where the outcome really matters, both the functional and the disease control. So I'm delighted that all of you are here, and I expect many Kasogians to join today and make the best of it. And now I hand over to our respected, honored, cherished, loved, beloved President, Dr. Rajashri Paladi, who has been a source of inspiration for all the committee chairpersons to put their best foot forward. So over to Rajashri for a few words of welcome. Yeah.
Yeah, thank you, Dr. Shobha, for the kind words of introduction. And I must say that uh, I'm overwhelmed by the kind of response the committee chairpersons are giving each time to the call of, maintaining the calendar of the events. And Rupesh, you have been very, very dynamic and giving in thoughtful and very robust programs for the Kasoga till now. And I must say that even this program is one such design program. I heartily congratulate you and your team,
Thank you.
along with Dr. Prerna, for bringing up such meaningful, value-based programs each time, which are of great impact for the clinical scenarios and for the management of cases. And having the best of them to do this is yet another feather in the cap. So, Dr. Veena Ranjan, Dr. Sundari, and Dr. Vinay Babu, we are eagerly waiting to hear from you. I wouldn't take much time because we are already running short. And then we are waiting to listen to Dr. Veena Ranjan about the roadmap to primary HPV screening and then now vaccination, which has come up in a big way. We are glad that the government also has taken the initiative towards reduction in the incidence of cancer, and we hope that the goals, the WHO agenda, can be attained as designated by 2050, so that by adopting such methods, we can really bring down and eliminate cancer, which is a dream for every obstetrician and gynecologist, especially the gynecologist working in the cancer preventive medicine, because this is only one aspect of the cancer in the humans, which we all know of the reproductive tract can be easily picked up and treated. So let's hope to see a cancer free society by the year 2050. And best wishes for the conduct of this webinar. Over to you, Dr. Veena.
ಟೀ ತಗೊಳ್ಳಿಲ್ವಾ?
Uh, shall I start?
Yes, Dr.
Please,
Veena.
please, please
Thank
do
you.
it.
Thank you so much for the kind words, ma'am. All of you have been so nice. It really feels so nice to be back to some program in Karnataka. I do go there occasionally for in Mangalore and in Bangalore also, but this is my first time with Soga, and I'm really happy to be with you people. Thank you, Dr. Rupesh, for giving this opportunity. So let me share my slides. I hope they're visible.
Yeah, you have started screen
Yeah.
sharing.
Yeah.
Yeah, we can see.
Okay, great. So first of all, no conflicts of interest because I'm going to take a lot of company names. So please don't think that I have any kind of collaboration with them, nothing at all. So today we'll be deliberating about the roadmap to primary HR-HPV screening. So essentially, we'll be seeing how we've transformed a paradigm shift from opportunistic screening to risk-based cervical cancer prevention. So all of us are aware of this 90, 70, 90. This has been the mantra when we talk about prevention of cervical cancer. WHO has called for elimination of cervical cancer, and to do that, we need to achieve these goals. 90% of girls to be fully vaccinated, and 70% are to be screened, and 90% have to be treated, whether pre-invasive or invasive disease. But what's important is this for us, from today's point of view. So 70% of women are to be screened with a high performance. So it is not our usual VIA or cytology. It is a high performance test, that is HPV NATs according to WHO, to get to this particular goal. So why primary HR-HPV screening, which is not available in many of our setups, right? Even JIPMA does not have it for routine screening. We use it only for reflex screening. So when compared to our usual cytology and VIA, it's got a very good sensitivity, almost up to the tune of 95%. That's the most important thing here. And it is very objective. It is not like, VIA, when you see, all of us will be aware that what the health workers refer to us as positive will actually be false positive. It's an extremely subjective test, actually. Similar thing exists with cytology also. The opinions from different pathologists will vary. They're not reproducible, these whatever tests are available. But you know that HPV DNA test is done on a machine, and it is very objective, and it is reproducible. And most important, it's got a higher negative predictive value, which can extend the screening intervals to 5 to 10 years. That is in resource rich settings. So due to these reasons, this is our best bet for the elimination of cervical cancer when we have to do the primary HR-HPV screening. Anyway, all of us will agree that we have failed miserably with cytology. We couldn't implement at all. VIA was actually better. States like Karnataka and Tamil Nadu did a lot in introducing via at primary care centers through by training the health workers and all this stuff, and we could see some pockets of good screening going on actually. But when it comes to primary HR-HPV, it needs support from the government. It needs support from NGOs, from for example, Bill and the Melinda Gates Foundation. That kind of support we need to implement this particular thing into our cervical screening elimination program. So when we talk about HPV, know that there are 12 HPV types. It used to be 14 before, which are high-risk HPV, but now it is 12 HPV types. And they are grouped as CHPV, that is carcinogenic to humans. They're further classified into 1A, 1B, 1C, and 1D. HPV 16 is sitting like the king on the top there. It's 1A. It's got the highest immediate risk of CIN3 and cervical cancer. It's responsible for almost 55 to 60% of all cervical cancers globally. And 1B includes HPV 18 and 45. Again, they are high risk, and the risk of adenocarcinoma, because they are the ones which are responsible for almost 80% of cervical adenocarcinomas. Group 1C and 1D contain the other high-risk HPV. So, we know that there are so many types of HPV, and please know that there are so many types of HPV DNA tests also. Globally, there are over 264 distinct HPV assays on the market. But unfortunately, almost 80% of them have not undergone stringent clinical validation. So be very careful before you, advise a HPV DNA test to your patient. Make sure it's a validated test. I have put up some tests over here. There are many more, but these are the ones which are WHO pre-qualified tests and India-specified validated tests and other FDA-approved options. So Roche Molecular Systems, Qiagen, Abbott, Cepheid, these are all like WHO pre-qualified tests. Multiple studies have been done and these have been validated. And India-specific validated tests, these are the 4 affordable indigenous molecular tests: HPV-Q, PathoDetect by labs, and recently, just few days back, this TrueNat HR-HPV Plus by Molbio was validated by group from AIMS New Delhi. Other tests like BD OnClarity assay, Cervista HPV test, Holodix, gene tests are also FDA approved tests. So before it's very difficult to remember all of them. So before you advise one particular test to a patient, see, the company representatives will come and tell us, we have already validated, ma'am, but please check it online, and then only you go ahead and advise a validated test, because the result what you're going to get should be validated. So another important thing we need to know is this high throughput centralized testing versus decentralized point of care testing. Like, if you're taking the swabs from many women and doing it in batches, in hundreds of batches running simultaneously in a central reference lab, that is what is high throughput centralized tests. Many of the Roche, Cobas, and Abbott, Alinity, all of them work like that. This is also used in a scenario where the self-sampling camps will mail in a drop of the sample, and then everything is taken to the central lab for accessing. Point of care is something where, the test will take hardly, it is like our urine pregnancy test, the card test, what we do. So it's not as early as that. It will take under 60 minutes, and it allows for a true single visit clinic experience where you can screen and treat immediately. So there is no loss to follow-ups when we use point of care tests, whereas in high throughput centralized tests, we'll have to ask the patient to come back to us where we might completely lose them. So it depends upon what is made available to you, and you should be using that according to the necessity. So how do we report this testing now? So you have done a test, it can be reported as no genotyping, only positive or negative. They won't tell you whether it is HPV 16 or 18 or 45 or 31 or whatever. They'll just give the report as positive, negative. Then there is limited genotyping. Like they'll identify groups 1A and 1B. Most of the tests will identify HPV 16 and 18. No, there are not many tests which are identifying 45 along with 16 and 18. And they'll pool everything else and say other high-risk HPV positive. Or nowadays it is CHPV positive. Now, another thing is extended genotyping, where they will tell you all the things, all 12 what we described, rather 14. They will tell all the 14 different genotypes, whichever is positive to us. This is how we'll get the thing. Full genotyping is not for clinical use. It will tell every HPV possible on Earth, so we don't need that. So no genotyping, limited genotyping, and extended genotyping. So basically, when we do limited genotyping or extended genotyping, we're actually doing a built-in molecular triage, which will allow us to stratify further and give prioritized management. Like no genotyping, we don't know whether it is the high risk H16 or 18 or it is other HPV. When we do limited genotyping, we'll get that information. So we are further triaging this particular test report. So another important thing is, I told in the beginning, HPV NATs, that is HPV nucleic acid tests are approved. So the nucleic acid tests include HPV DNA tests and HPV mRNA tests. mRNA tests, the advantage is these will detect the E6, E7 oncogene transcripts. Please know that HPV DNA test will detect only the genetic material. That means HPV is there, that's all. Whether it is going to lead to cancer or it is going to get cleared off or it is going to stay, we don't know anything when we get a HPV DNA positive test. It may be just a transient infection. We really don't know all those things. But when we do an HPV mRNA test, it will specifically detect the E6, E7 oncogene transcript, which means that the disease is transcriptionally active, which will transform the viral infections into higher clinical specificity and reducing false positives from transient infections. So it's very important to remember this, that HPV mRNA is one step ahead of HPV DNA test. The FDA approved test is Optima HPV assay, that is by Hologic. And WHO has told that if you're using HPV mRNA test, then your screening should be done once in 5 years rather than 5 to 10 with HPV DNA. Because there are not many studies to say that it can go beyond 5 to 10 years. And they're not for self-screening. It cannot be used for self-screening. And most important, how I would use it is they can use as a further triaging method once HPV DNA comes positive. Instead of directly going and treating or doing further workup or whatever, we can use HPV mRNA if it is available to further triage. And remember one thing, they are much more expensive and not very easily available when compared to HPV DNA tests. So if HR-HPV test comes positive, what is the goal of a management? Essentially, we have to separate transient infections from transforming infections. Transient are, it will get cleared. Transforming are something which will transform the HPV infection into cervical precancer or cancer. So when we get a positive report, this is what is going to happen. The woman is worried that she has a test which might mean that she may have cancer. And the doctor also is worried. Why the doctor is worried? Because we used to fight with these algorithms. So many different algorithms to remember, go through and all this stuff. So one such algorithm is here, which is put forward by Foxy for HPV testing. When we use HPV testing as the primary testing, this is how the whole algorithm used to go. I'm not going to go too much detail into this because now the whole scenario is changing. So just know that if HPV negative, they'll go back to routine screening. That is usual in any kind of algorithm. If it is positive, either you can go directly to colposcopy or you can go further triage with VIA or cytology or go do genotyping and then do whatever. So a complicated algorithm is what we used to follow till now. And then came the ACCP online risk calculator. I really used to use this a lot actually. It's very easy to use. If you use it in the laptop on web, it is free of cost. And if you want to have it on your mobile, then you have to get a paid app downloaded. It is very easy to use. You just have to put in very few information, the age of the patient, the clinical situation, what test is positive, what was the previous test. That's all. Put that much, you will get the report like this. What is the immediate CAN3 plus risk and what's the recommended action? The whole information used to come. And this is the website, whatever the address, web address for this particular site. And this was very useful according to me. But then this particular thing came where when we did further extended genotyping, either limited or full, we used to go for direct colposcopy if it is SPV 1618 positive. This was just 1 month back. I used to use this particular thing for treating patients. Okay, and if it is other HR-HPV positive, then we go for reflex testing using VIA or liquid-based cytology or dual staining. A word about dual staining here. Dual staining is essentially, it will simultaneously detect the expression of P16, the marker of oncogenic HPV activity, and Ki67, which is a marker of proliferation. So it is a triaging test again. So if you have HPV 16, 18, you know it is high risk. So go directly for colposcopy. If you have HR-HPV, other HPV positive, then go for reflex testing. This is what was done 1 month back. So what happened in the last 1 month? In May 2026, WHO came up with these guidelines. WHO guideline for screening and treatment of cervical precancer lesions for cervical cancer prevention, use of human papilloma virus DNA genotyping. Okay, so this particular document was released last month, and the whole scenario has changed. It's become extremely simple now. Okay, we don't need to go through very extensive algorithms or use a calculator online. Nothing. Okay, so essentially what WHO has done is they distinguish two operational paradigms. It's extremely important to have this distinction because there is a lot of difference in this local healthcare infrastructure, resource availability, loss to follow-up risk, none of them. See, obviously ASCCP was devised for countries which were well-to-do, the resource-rich countries. Okay, but WHO has to think about everybody. So it thought about everybody, and it had came out with two things: resource adequate settings and low resource settings. Resource adequate settings are also known to have high follow-up capacity. So there they use screen, triage, and treat. And in low resource single visit settings with low follow-up capacity, WHO recommended screen and treat approach. So how did these particular things go about? Now we'll just have a look at it. So in settings where the follow-up was high and resources were good, WHO said you do HPV DNA extended genotyping. If it is negative, rescreen in 5 to 10 years. If it is positive for HPV types 1A, 1B, or 1C, what I've already mentioned, treat them. There is no need to do colposcopy. There is no need to do anything. Directly go for treatment, either ablate or excise, depending on their eligibility. If they're positive for HPV types in group 1D, where the risk of malignancy is much, much lower when compared to 1A, 1B, 1C, then you triage them. Triage them with colposcopy because it is a high resource setting. And then manage according to the colposcopy diagnosis. But for settings with low resource and low follow-up capacity, what WHO recommends is treat all eligible women with ablative treatment who test positive for any carcinogenic HPV. Okay, whether it is 16 or group 1D, 39, 51, 56, whatever it is, treat all of them. So it is consistent with the no genotyping approach. Makes sense because I really don't know how many of us will have access to this extended genotyping. It's not very simple, right? In primary care setting or in a community setting, when we're doing camps and all this stuff, probably we'll be able to do only one test which will say plus or minus. So here it is like, literally we are treating as if we did not have access to any of this extended genotyping. So if a program provides triage with additional tests, WHO suggests use via or colposcopic impression. This is in low resource setting and low follow-up capacity without histological confirmation. No need to take a biopsy, wait for the report and all this stuff. Just visualize the cervix with via or colposcopy and treat immediately, either ablate or excise. No need to depend on cytology or dual stain because you may lose the patient for follow-up because the low follow-up capacity is what should be underlined over here. So how do we summarize this whole recommendation? Now, in high follow-up capacity, do extended genotyping, and in low follow-up capacity, treat all HPV positives. If you go through this document, which has come last month, WHO will give multiple options, and it will say, I prefer this is preferred over this. This is preferred over this, over this. It will keep on giving multiple options. The top layer is the one which is actually recommended. Others are suggested by WHO, but whatever said and done, the evidence for any of this is low. To be frank, there is no great evidence coming up. This is only keeping in the mind that we don't want to lose out women for follow-up. So what about women living with HIV? Okay, here there is no treat all women because the most important point we have to remember is when we go and meddle with the cervix of these women, the viral shedding will increase. You have done excision or ablation, the shedding is going to increase. So WHO suggests here you go on with your either limited genotyping or colposcopy via or cytology, triage these women after a positive HPV DNA test. Don't go for direct treatment the way we discussed till now. So what are the limitations and challenges now? But as I already mentioned, the evidence is low certainty in many of the WHO recommendations. And HPV assays what are available commercially, they don't detect 1A and 1B. 1A and 1B actually include 16, 18, 45. But most of the kits, when there's limited genotyping, will detect only 16, 18. 45 is not detected. And interpretation of extended genotyping requires provider training and robust algorithms again. And genotype-based triage may increase complexity in health systems that are already struggling with follow-up. And most important, cost is another important consideration. So it is not going to come up in a big way in our setup. So it's better to stick to treat all the HPV positive women. So treatment options, I think Sundari madam is going to speak about it. So I won't go in detail. We use ablative or excisional methods, and the eligibility for ablative and excision should be looked at strictly. If the lesion is eligible for ablation, only then we'll ablate. Otherwise, we have to go for excision using leads or a cold knife conization. But most important, I think again, this will be dealt in more detail. I just want to emphasize here, be careful about treating young women in using this particular guidelines who have not yet completed their family before going directly for excisional treatment without triage. In this particular set of women, I would still want to go for triage rather than directly going for excision. Ablation is no problem, but excision, we should not directly go in this particular scenario because of all these complications. So now coming to the revolution of self-sampling. So all of us will agree that when we go for camps to screen for cervical cancer, many women don't come forward. We will take 100 sim speculum and all this stuff and hardly will be using 25 to 30 because whatever advertisement we have done, whatever counseling we do, many women don't even come out of the house because they don't, many social, cultural issues are there. All of us are aware about it. But what's important to know about self-sampling? Self-sampling came, we were all very happy. Okay, good. At least now women will, come forward and get screened. But it's not. Again, there are typical problems. I'll tell a little bit about it now. So it's proven beyond doubt that self-sampling is non-inferior to physician-collected samples. A lot of studies are there which have proven that it's as good as your physician-collected sample. And obviously, it allows validation of even dry or buffer transport media. About Simply Collect is actually dry collection. There is no collection media, nothing over there. And obviously, it will bypass the need for a pelvic examination for primary test. So socioeconomic impact is also going to be there. It will also, it will be useful for us to screen the underscreened rural or culturally conservative populations. This is a very important structured framework here. Patient selection and eligibility. What's most important to understand is self-collection is an opportunistic tool designed to bridge an access gap. Okay, we are not able to screen women, so we want to utilize this particular to bridge this gap. It is not a blanket replacement for all pelvic assessments. Extremely important to understand this. Ideal candidates are those who have average risk, asymptomatic, and their age between 30 to 65, who are due for a routine screen and who are refusing a speculum examination. So ineligible population, please remember this: symptomatic patients, no self-screening. High-risk individuals, no self-screening, and patients who are under surveillance for prior high-grade dysplasia, again, there is no role of self-screening. All these patients require clinician-collected cervical samples. So this, again, we cannot collect samples with whatever we feel like collecting. There are validated collection devices, Copan swab or Evelyn brush. This is a Copan swab. This is Abbott Simply Collect, the dry whatever we collect. And then this is Evelyn brush. So we have to use these validated systems to collect the self-collected sample. But please remember, there are certain advantages of clinician collected sample over here. You know that samples which are collected by physician are going to be directly scraped from the cervical transformation zone, capturing cells for immediate reflex cytology or dual stain out of the same wire. A negative result gives a 5-year safety window, whereas a negative self-collected sample will give us only a 3-year safety window. So these are the advantages. This is the most important thing. We can use the same sample to go for cytology. Whereas we cannot do that with a self-collected sample because it's just collected from the vagina, not from the cervical transformation zone. So how to collect this sample? There are a lot of this kind of images and videos are available online by WHO in their website, which should be shown to the patient before we ask them to collect this particular samples. So going one step forward, self-collection, if women are getting scared to put something into their vagina, there are certain other ways of collecting. Collect the urine. The Colip is the system which is approved by FDA, where they collect the urine, the first void urine, the initial part of the stream has to be collected because it's assumed that when urine comes out of the urethral meatus, it will collect all the cells and whatever is lying at the urethral meatus in the initial part of the urine. So that should be collected. Please remember, we collect midstream clean catch urine for urine culture. Here it is the first part of the urine which has to be collected. Then we can look for HPV samples in menstrual blood also using M-strip. And there are some tampon devices coming up, but none of them are, as of now, they are not standard of care. So to take home, the screening is no more visual, it's molecular now. And we should use only the validated HPV NATs. Genotyping prevents colposcopy clinic overload, and self-sampling is the bridge to the unscreened. So we have to tailor whether we want to use high throughput or point of care depending upon where we are working. So all said and done, what I would like to emphasize is continue screening eligible women with whatever is available at your setup till valid HPV nucleic acid tests become available. That's very, very important. I'll just close my presentation by saying that a screening program's true power is not determined by how accurately a machine detects a virus in a lab, but by how many positive women we successfully track, risk stratify, and cure before they leave our clinic doors. These are my references, and thank you so much for the patient listening.
Uh, Honestly, Dr. Veena, being a GYN oncologist myself, pardon me for the bad background light because I'm traveling from Mysore back to Bangalore. But honestly, being a GYN oncologist myself, just being into oncosurgery extensively, the most important part of cervical cancer, because cervical cancer, eventually everybody thinks it's like early cervix surgery and later on it's just radiation. So screening ಬಗ್ಗೆ importance, as you so beautifully you have brought it out, that we literally listen to it just like school teacher ಹೇಳ್ಕೊಟ್ರೆ ಹೆಂಗೆ students ಕೇಳ್ತಾರೋ, literally that is how I have actually sat today and listened to your talk. I mean, thank you so much. I'm sure that ನಾನು ಹೇಳ್ತಿರೋದು ಉತ್ಪ್ರೇಕ್ಷೆ ಅಲ್ಲ ಅಂತ ಅನ್ಕೋತೀನಿ. I'm sure all of the people who have logged into this meeting will definitely agree with me. It was a fabulous presentation wherein you actually simplified, because ಎಷ್ಟೊಂದ್ಸಲ the moment we see so many kind of different kits, mRNA, DRNA, I mean DNA, ಇದೆಲ್ಲ ನೋಡ್ಕೋಬೇಕಾದಾಗೆಲ್ಲ everybody ನಮ್ಗಿದು ಬೇಡ ಅಂದ್ಬಿಟ್ಟು we kind of push it away. But you have simplified it so beautifully that I'm sure that all the people who have logged in today, and of course, since the meeting is being recorded, we would definitely love to share this with people who are interested in our Kasoga group. And we will definitely look forward to, I will try to
Thank you,
liaise
Doctor.
myself with you and Jipmer, if possible, for any kind of help that we need. And thank you so much for this fabulous talk. You have beautifully summarized things. Tumba simplify ಮಾಡಿದ್ದೀರಿ. Thanks a lot. And I'm sure that now Sundari madam, who's my teacher, a beloved teacher, I should say, will definitely be upbeat after your talk to present her talk in an even better way. I mean, because madam, I know that she's so
You can't
passionate.
compare
Madam,
me to Sundari ma'am, Rupesh.
no, 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 no,
Sundari
no,
ma'am is all our teacher.
no, no.
On.
I,
Both
I,
of
I
you
agree, but
stop here.
madam
Both of
will
you
be.
stop.
Madam will be so
Oh,
happy now because Madam US ಇಂದ she is logged in.
I
Madam
know,
is US ಇಂದ
okay.
login ಆಗಿದ್ದಾರೆ. And thank you so much, Dr. Veena. Much to say, I will definitely say later because we are running short of time. Madam,
Dr. Rupesh,
Madam,
Dr.
yeah, it's
Rupesh,
for you,
can I say
madam. Yeah,
something about Dr. Veena?
please,
I mean,
madam.
just as you said, na, she has made it such a meaningful program, so simple and easily applicable to everybody. And this is
Absolutely.
on YouTube. All our Kasoga webinars of committee chairs will be on the YouTube. So
Fantastic.
anytime our Kasogians and anybody who wants to gather the knowledge and information is always there on the YouTube. So that is
Thank
the
you so much,
advantage
madam.
that, yeah, we have the link.
And thank you so much, ma'am. You are also one of the inspirations because ನೀವು ಎಷ್ಟು aggressive and active ಇದ್ದೀರಿ ಅಂದ್ರೆ it actually inspires us. And thank you so much.
Yeah.
We'll over to
There is
Sundari
so
madam
much
now.
of potential in Karnataka, you don't know.
Absolutely, ma'am. Absolutely, ma'am. Absolutely. Over to Sundari madam now. Prerna, are you there, ma? Could you please introduce madam?
Hey, no need of introduction. Yeah, we'll just start off.
Ma'am, no, ma'am, just very briefly, ma'am. As all of us know, Sundari madam doesn't need introduction, very true. But at the same time, madam is somebody who has been a doyen of, selfless work towards preventive
Cool.
gynecology. And madam has been extremely active, not just in the field of GY and preventive gynecology, but also she's been she's had wonderful, stupendous years of teaching. And we every single time, every single CME or conference where madam is there, we all still go, and as students we would love to listen to her, and we are very much curious, and we want to know more about this topic. I'm sure all of the listeners today who have logged in are also waiting for your talk, madam. Over to you, please, ma'am.
Thank you. Thank you, Rupesh, for kind words and for giving me this opportunity to speak about the subject which is very close to my heart. Can I share my slides, please?
Arun Avre, please.
Yes, ma'am.
Arun, allow me to share, no?
Yeah, ma'am.
Can you see my slides, please?
Yes, ma'am.
Am I
Yes,
audible?
Sure, ma'am.
Okay, thank you. See, this is, wonderfully, Veena has given us what to do, and most of the things what I'm supposed to talk, Veena has already spoken. So probably this is, I'm just going into the clinical scenarios. The latest WHO's classification of C, HPV and all. Anyway, she has spoken to us. I'm not touching any of those things. I'm just going into the clinical scenarios, what we face every day, and then how we have to deal with them. Now, this I think all of us have gone through. 28-year-old lady comes for a screening, and then she's HSIL, then followed by biopsy. CIN2, and then she's advised hysterectomy because the gynecologist sincerely says that it may progress to cancer, so it's better you get a hysterectomy done. She's not very willing. On second opinion, she goes and wait for 6 months and then come back. We'll do another biopsy. One more gynecologist says. Now, what happens to her? She's confused, and is what is right for her now. So this is what we are going to see in next few minutes. How do we triage these women when they come with the histopathology reports of CIN 2, 3, 1, I'm not talking CIN 2 or 3. And also, of course, the same report if we get in a special situations like a pregnancy or HIV positive woman. This I think every time when we start these topics, we start about this elimination by 2030. All of us are in this, and everybody's responsibility, all not only gynecologists, every doctor's responsibility is to see somewhere or other to eliminate. So what happened is the shift is from when we were there very early in our teaching days, downstaging to the cervical cancer we are talking about. But now from there, we have moved on to elimination of cervical cancer because we have a call from WHO. How do we eliminate? There are two things by which we can eliminate this. One is the vaccinating all our children at the proper age, both boys and girls. In that, Australia is the first country which declared that it has eliminated cervical cancer. And one more thing is treating the pre-malignant lesions appropriately is the word I want to stress here, because lot of over-treatment is done for this. And in some situations, even under-treatment happens for this. So today's topic and our task is to know what is appropriate treatment for these pre-malignant lesions. Now, what are the pre-malignant lesions? All of us know cytology, ASCUS and ACSH, and intraepithelial lesions, LSAL, HSAL. Unfortunately, now the glandular lesions, which used to be only 5%, 95% used to be the squamous lesions. Now, glandular lesions have taken over. They are up to 20%. So, there is another problem for us is to diagnose the glandular lesions. But this is not very easy as a squamous lesions to diagnose glandular lesions, even by cytology or even by colposcopy. So we have to be a little careful about glandular lesions. So I'm not touching on the glandular lesions and their management. And this we have to remember. Now, histopathology, we have been knowing that CIN 1, 2, 3. Latest even histopathological diagnosis is given as LSIL and HSIL. Why is that? This is the lower anogenital squamous terminology has been introduced for not only cervix, but vulva, vagina, even a perianus, penis, all these lower genital tract lesions, squamous lesions, that is HPV associated lesions are histopathologically classified as LSIL and SHIL. Though in our city, Bangalore, still the pathologists are not used to giving it. Very few labs are giving it like HSL and LHIL. But we have to remember that this has been incorporated instead of CIN 1, 2, 3. Now, why this two-tier classification? Because CIN1, as we know, is the lesion which is not supposed to be progressive, and it only indicates that it is HPV infection. CIN3, on the other hand, we know that it definitely progresses to the cancer and we have to treat. But in between CIN2, what happens to CIN2? Always we used to say, if you see the literature, say traditionally it is aggregated as CIN2 plus lesion. Whenever they talk about the management of pre-malignant lesions, it is spoken as CIN2 plus. That means alone CIN is not spoken so far because isolated CIN has a unique biological behavior. What is its behavior? First thing is inter-observer variability for reporting is there in when it is given as CIN2. If you ask two pathologists, somebody may say it is CIN1, somebody may say it is CIN3 also, it can be. So that possibility is there for CIN2, whereas it is not there for CIN1 and CIN3. I'm not going into pathology, histology part of it, but it is like that. Now, because CIN2, there is a high probability of spontaneous regression compared to CIN3, it is a confusion. What should we do when it is CIN2? So now there is a WHO has come out with a solution for that. CIN2 lesion, it is cannot be differentiated only by doing the histopathology report. For CIN2, when it is given as CIN2, we have to have an incorporation of either dual testing or P16 marker, IHC marker has to be there along with that to give a proper report about it, whether it is tending towards high risk or whether it is tending to low risk. This is the situation as far as CIN2 is concerned. And though we need to be very clear about it, no, this is what we know about it. CIN1 to CIN3, going into cancer, it may take anyway 10 to 15 years. We don't need to be hurrying saying that today you have come with a CIN2 or CIN3 report, or next tomorrow or next within 6 months you are now going to get a cancer. No. But of course, it depends on many other factors. I'm not going to the details of the factors. Depending on that, it may take anywhere 10 to 15 years. We need to remember that. Now, this is IARC has given this clearly the rate of progression, regression, and persistence of these lesions. CIN1, when you take it, as we know, the most of the lesions will regress. That's why it is not considered as pre-malignant now. We don't treat it unless it is persisting for a quite long time, say about 2 years. Now its persistence is 10 to 12%. See, the malignancy, progress to malignancy is less than 1%. That's why it is not considered as pre-malignant. Now, coming to the CIN2 again, see the amount of regression it is. Quite a percentage of regression of these lesions do occur. 50 to 60% can regress in 2 years' time. Now, only the small amount will progress, and 5% is a chance of cancer when CIN2 is left alone for a longer time. Now, of course, CIN3, it's a high-grade lesion. So one thing we need to note is even in CIN3, there is a chance of regression for up to 30%. So this one thing we have to remember in situations where we deal with a situation where you just cannot do immediately the definitive treatment. Probably this will help us. The progression and regression rates depend upon the patient's age, immunological status, and the type of carcinogenic HPV infection. Here, I tell you one thing is epigenetics plays a very, very important role. I'm not going into the details of what is that, but all the women nowadays, what I explain to them is their lifestyle, their food habits to change so that these lesions will regress. So epigenetics have a great role. We'll talk something sometime later about this and then the pre-malignant lesions. Now, how do we clinically manage CIN1 is our main concern. Three-tier system, if you take CIN1, not a pre-malignant condition, so we are not going to treat it. We are going to only keep her under surveillance. And then maybe if the lesion is persisting for more than 2 years, probably we can give an ablative therapy. If it is not progressing, but it's only persisting, probably ablation we can think of. Yes, we have to do ablation if it is persisting for more than 24 months. Now, what about CIN2? Higher regression rates, as we have seen, especially in a younger woman. So we don't jump and try to treat them, especially in a younger woman. So we can have a surveillance for them. Now, CIN3, as we have already said, it's a high chance of progression, except in a very few situations, probably the treatment is the answer for CIN3. Now, when we come to the two-tier system, which we are going to get into after some time, LSIL, if it is given as a histological diagnosis, still we go for a observation. HSIL, it has to be given now as in the bracket CIN2 or CIN3, favoring CIN2 or CIN3. As we say, is ASH, whether favoring the high risk lesions or not. When we say in the cytological, we have to say here also it has to be given by the laboratory. There is a paradigm shift in the management of these lesions, and as I said already, biomarkers are advised to evaluate the CIN2 lesion. When it comes, we have to do a biomarker or a dual testing, and just come to that. Now, what are the management protocols, management options we have for this woman? Surveillance, as we said, ablative therapy, cryothermal laser ablations are there, but cryo is not now. Thermal ablation is more and more is spoken about, and it is more effective, more convenient in many ways. So most of us are shifting over to thermal ablation, and of course, excisional therapy. Either the LEAP, or in certain cases where the LEAP is not adequate, we may have to go for cold knife conization also. And the treatment depends on, it is not a just blanket statement to say this lesion is this treatment. It depends on, again, age of the person, fertility desire, and type of the transformation zone. We have to remember hysterectomy is unacceptable as a primary treatment for pre-malignant lesions of skin. This I stress again. Please remember, hysterectomy is not the first treatment. So now we'll go to a few case scenarios and then quickly see how we are going to manage. 30 years, but she's unmarried, but sexually active, comes with a pap smear report of HSIL. And she has, of course, she has to undergo colposcopy and biopsy is done. Report comes as HSIL. Now, what are the management options we have? We have seen the management options, but she's a young lady. So what do we do for her? As Veena has already said, I'm not going into the details. This app is available. We can download and use it, but I don't think it's very suitable for our conditions in India right now. So what do we do with this now? Thus, if it goes, it will tell you the risk, what she is going to be having a risk or not. So deciding on that, I mean, depending on that, we can decide the treatment. If it is not feasible for us to do, this is what we have to think of. CI2 is not a lesion to be treated automatically, but rather there's a paradigm shift in that again. It's a personalized management integrated with epidemiological and clinical data supported by biomarkers is the one which is followed now. So what do we do for her? Either we have a dual test. I don't know, in Bangalore, laboratories dual testing is not done, but routinely now they are incorporating P16 IHC report along with CIN2. Many labs are doing it. I said dual testing is easy, but they said still we have not started, madam. I spoke to cytologists and pathologists, a few labs in Bangalore, but they're not starting. But it is easy, I think, if they can start. Anything, if the dual testing or IHC has to be incorporated into when we have HSIL in the bracket CIN2 lesion. P16, if it is negative, to treat the lesion as a CIN1, that means it's only surveillance, there is no active intervention is needed. If she is P16 positive, we have to consider the lesion as a CIN3 and to be managed accordingly. Either Edwina has beautifully explained to us, see and treat what WHO recommends now. That can be done, or we can take again the treatment can be see and treat. If it is not possible, probably we can take her otherwise and then treat if she is coming. Now, this is what is called dual testing. Same the LBC sample, what we have taken from the sure path. And then that has to be, instead of hematoxylin and eosin staining, they will do the dual staining. In this dual staining, usually what happens is P16 and Ki67, both will not be incorporated into a single cell. If both are incorporated, and if you can see these dual staining in a few cells in the pap smear, that is supposed to be dual staining positive. Here it's beautifully said, this is the cytoplasm is stained brown and the nucleus is stained red. Red is for Ki67, it stains red the nucleus, and the P16 will stain the cytoplasm brown. Once this is there, dual staining, what does it mean? The P16 is proliferating and progressive, and Ki67 is proliferating because I don't go into the details because they inhibit two proteins which can prevent the oncogenesis progress in the cells, but those are prevented. Retinoblastoma and then the P53 are inhibited by this. So the proliferation of the cells and progression to the cancerous lesions can happen. This is 60. Now, coming to this, WHO recommends this, reduces because if we do this with what we are doing LBC, in that only if they can do, colposcopy burden will come rest, and negative dual staining can be reassuring, and then we can repeat after 24 months HPV DNA NAT test, we can repeat in such patients. Now, coming to the P16 and CIN2, yes, same thing I told you, P16 promotes the cell proliferation and progresses to the cancer. So if P16 is negative, why P16, all this I'm not going into the details now, the time is short. So if it is positive, probably it is going to progress, so we may have to give the treatment. If it is negative, probably we can put her into the surveillance. Now, this lady, now we have done the P16. If it is negative, we'll ask her safely to come back after 6 months for a colposcopy and see if there is a lesion is progressing or regressing. If there is no progression of the lesion, maybe after 6 months, in 6 months, we can do colposcopy and then follow for 24 hours. If it is not progressing, she will go back to the routine screening. Now, suppose she is 16 positive and she is not willing for any treatment right now because she's unmarried and she's planning to. Can she be under surveillance? Yeah, there are few literature surveys show that there are few articles which have come up. Even though she is positive, depending upon the situation, if she is not willing, if she is not willing if it is positive, we may have to do her only excisional treatment. If she is not willing, at least one thing what we could say is ablative therapy, which is not going to affect her fertility. We have to explain to her. In spite of it, if she's not willing, yes, there is some place. If she is very, very prompt for the surveillance, we can allow her for some time surveillance. That is not mine, but there are a few literature surveys shows that yes, they can be with a very close monitoring and explaining the risk, we can keep them under close monitoring. Now, 40-year-old lady, HPV DNA test is done. It is positive, and then because of that, she had the this is the colposcopy report of hers I have done, and CIN2. What is the management for her? Now, this is spontaneous regression because of the 40 years age of the patient, regression chances are very less, and so she can go for treatment. Thermal ablation can be done for her. It can be see and treat because I have done the colposcopy at the same time. Take biopsy and do even without taking the biopsy. Now WHO recommends, Veena has explained to us, we can go for see and treat. Thermal ablation can be done here itself. Excisional therapy is propose if she is not suitable for thermal ablation, then we may have to go for excisional therapy. What are the criteria for thermal ablation is the lesion has to be entirely on the ectocervix. It must be transformation zone must be type 1 and type 2. The lesion should not be occupying more than two quadrants. Here we saw in the picture it was only one quadrant it is occupying. So, and then there is no suspicion of the malignancy invasion. In such cases, we can do thermal ablation very safely, and then we follow up them later. Now, this is the thermal ablator. It is very, very handy now. We can use thermal ablation. The advantages over the cryo is the big cylinder of nitrous oxide and the R carbon dioxide. All those things are not there. And then if it is a wider lesion, with the cryo probe, it is not possible. The same thing with the thermal ablator. Multiple touches can be done with this very easily. The entire transformation zone can be ablated very easily, which may not be feasible with the cryo probes which are provided for us. Now, immunocompromised woman, if it is she is HIV positive, 28-year-old lady, HPV DNA NAT is 18 positive, colposcopy CIN2. Now, treatment here is excisional of the entire transformation zone. Any HIV positive woman, there is no conservative management. It is an excisional therapy, and we have to be sure that margins are clear in her case. Now, in summary of CIN2 management, conservative management is possible and it has to be done in younger women. And we have to keep them under surveillance. If the age is more than 35 years, we can go for ablative therapy. And again, I insist on that hysterectomy has no role in treating these patients. Now, 42-year-old woman, and LBC is HSIL, and we have done this is again, I have done the colposcopy for her. Sweet score is 8, and the biopsy is done, and she is CIN3. Now, what is the treatment for CIN3? No ablative therapy, even she is young, no ablative therapy, except in few cases. Not going to the details of it, no ablative therapy, only excisional therapy. Entire transformation zone, it is not the lesion alone we should not take out. We have to remember whenever we have done this excisional therapy, even ablative therapy, entire transformation zone has to be either ablated or excised. Depth of excision is 7 millimeters. If it is type 3 transformation zone, probably the ideal would be cold knife coning for her. Or in case of adenocarcinoma in situ, we have to do cold knife coning rather than leap. Of course, in a very experienced hands, we can do top hat method. We say, I'm not going to the details of it. We can do the leap, but it's ideal because the upper end of this one we don't see, especially in AIS lesions. We don't do the leap because skip lesions are very common in that. We can miss that in the endocervical canal. So ideal for AIS is conization. For CIN3, yes, it can be. If it is expertise is there, we can do leap also. The margin should be free and a micro invasion has to be ruled out. Hysterectomy is not the primary mode of treatment, even for CIN3. Even if we want to do, our patients insist on CIN3, we have to do leap and we have to exclude the micro invasion. Then only we have to go for hysterectomy. Suppose we have done hysterectomy with the CIN3 biopsy report, and then it comes as a micro invasion with the depth of invasion more than 3 millimeters. Now, our treatment will go insufficient for the patient. We have to remember that. This is the multiple passes can be there if the lesion is extensive. And we have now the swits and the knits also. That will be better. With the single needle, we can do the excision very neatly, if not with a loop. Now the follow-up is after 12 to 18 months we have to follow, because HPV DNA test is the ideal test. That is called test of cure for all these people for follow-up. If it is not possible, we can use VIA or cytology. Usually we don't, but VIA can be done. But it should be done only after 12 to 18 months, because HPV DNA will take at least minimum 12 months and 24 months for clearing off. If we do HPV DNA test before that, it may be still positive. So we have to wait for 12 months minimum after the treatment to repeat the HPV DNA test. That is a test of cure. And these women, once they are treated, they have to be followed up for 25 years. No role as a, what is the role of hysterectomy in CIN? No role as a primary treatment for either CIN 2 or 3. Recommended after excisional therapy if margins are positive, persistently if the margins are positive, or suppose in a postmenopausal women we have done the leap and then there's a short cervix or it is flushed with the vault, the margins come positive. Such women probably we can do simple hysterectomy. And if it is a recurrence occurs after the ablative therapy or excisional, if the recurrence occurs, next we don't go for ablation or excision. That time it is but hysterectomy to be done for this patient. Now the last scenario, I think I have 5 minutes time. Do I have 5 minutes? One of you? Can you tell me? Arun, do I have time? 5 minutes?
Ma'am, please go ahead,
Ma'am.
ma'am. Please complete the talk.
Just 5 minutes, Rajeshri. Thank you.
Yes, ma'am.
Just 5 minutes. See, this is a
Please go ahead,
30-year-old primary gravida, 14 weeks of pregnancy, had a spotting PV. As usual, we have done obstetric, excluded the obstetric causes for the bleeding. So pap smear was taken to her and it was HSIL. Now, how do we manage her? She's only 14 weeks of pregnancy. Low-grade lesions, reassessment only 3 months after delivery. If it is HSIL, as in this case, we have to do colposcopy for her. One note on this colposcopy is the colposcopists must be very, very experienced because we are not doing routinely pap smear and colposcopy in a pregnant woman. So our expertise in doing it is limited. So we need to be very, very careful because of the hormonal changes. There's a lot of change in the colposcopy picture as well as in cytology in this woman. So we need an expertise to do the colposcopy, but we have to do colposcopy for her because she's only 14 weeks. If it is 32, 36 weeks, I would not have done. And I would have said, yes, you finish the delivery and then we will reassess you. Now repeat, because colposcopy has to be done in every trimester of pregnancy for her to see the progress of lesion. If suppose the lesion is progressing, we may have to take a biopsy for her also. This is it because CIN lesions are increasing during pregnancy because of the age. Women are postponing their pregnancies, so age is increasing. So the CIN possibilities are increasing during pregnancy. We have to remember that. But one thing, good thing, what we have to remember about it is CIN3 will not affect the course of pregnancy. Rather, the pregnancy will not affect the course of CIN. What do I mean by that? CIN usually will not progress during pregnancy, but there is a literature which says that there is a regression of lesions can occur during pregnancy, these CIN lesions. So hurriedly, we should not do any treatment. We should not threaten, give the patient, saying that this may progress, this may become cancer. No. We have to be cool and tell the patient also to be cool and enjoy her pregnancy so that the regression, see, the literature says up to 10 to 70% of these people will regress the lesion once the pregnancy event is over. Progression occurs only in 3 to 30% of people. So it's ideal to wait, not doing anything except
What is that?
biopsy can be done. So this lady, we have done a colposcopy and then the biopsy has been done and it is CIN2 lesion in her. Okay, now the biopsy can cause bleeding, but need not worry. A simple biopsy can be done with, but ECC cannot be done. Even though transformation zone is type 3, you have seen the colposcopy, but we should not do ECC. Endocervical curettage, we should not done in this woman, but cervical, ectocervical biopsy can be done in this patients. Now biopsy report, CIN2. If it is CIN1, no intervention, repeat evaluation after 1 year after the pregnancy event is over. If it is CIN2, our patient is CIN2, colposcopy every trimester of pregnancy and reassessment of the lesion in every trimester, intervention when the lesion progresses to, but unlikely because there is a chance of regression. Treatment should be delayed until after delivery, 6 weeks to 3 months after delivery. We can delay the treatment for this patient. Again, what we need to do is treatment depends on reassessment. After the pregnancy event is over, we have to reassess her by colposcopy. If the lesion is there, take a biopsy, and if it is positive, then we have to think of treatment. CIN3 has a high progression rate, hence treatment is necessary. Excisional therapy is preferred over ablative therapy. Post-treatment follow-up is necessary. CIN2 is an equivocal diagnosis, so additional tests are recommended to confirm whether it is progressive lesion or a regressive lesion. Surveillance and ablation therapy are recommended in a younger woman. No active intervention for even CIN3 during pregnancy. Hysterectomy is not a primary treatment for CIN2 or 3 at any age group or any state of pregnancy except in HIV positive women. Thank you very much for your patient listening. I thank Rajeshri, I thank Rupesh, my dear student, and I'm so proud of him for giving me this opportunity. Thank you all of you for patient listening. Thanks a
Ma'am,
lot.
such a beautiful presentation, ma'am, telling us all the details about how to progress with the CIN once we diagnose it. Many a times there's a panic in the patient and also the attenders and also the referral doctors or the GPs who the minute they read it as CI and then there's a huge hue and cry to motivate the patient towards hysterectomy. And also some doctors, because when the patients come from the periphery, it's very difficult to convince them, and for the fear that we may lose the follow and they may not come back for the treatment again and they may not compile by the advice that we give. Many of the doctors resort to hysterectomy, and I think this
Oh, that time,
presentation.
you know what, Rajeshri, that's what WHO has said. See and treat or even screen and treat is there. Okay. You do them ablative therapy. Now WHO have gone to the extent of HPV DNA positive, you do ablation without doing anything also.
Exactly,
So such
exactly. So
women,
the
when they come to you,
ablation
just ablation.
very
Yeah, all
easy
of
to
us
do
must
for
have a
ma'am.
thermal ablator. Yeah, all of. I mean, I'm not promoting it, but it's
Yes.
very handy. All of us, if we can process one thermal ablator, all these problems we can just see and treat or screen and treat, and then we can send them off.
I think under your guidance, we'll go for a workshop, madam, for doing this
Sure.
thermoablative
It will be
treatment
a
and
great honor to me
CIN
and
and
my pleasure,
infertility. Yes,
Rajashri.
yes.
Really, because this is very, yes, all of in Karnataka. See, my whole aim of my life is Karnataka should be free of cervical cancer. And in a very, very miniature level, I'm working in the rural places. I'm doing, no, for the last for 13 years, I've been working in Chikbalapur district. Population-based screening I'm doing. I don't want to waste the time now. So we can have workshop. We will
So
do.
from Kasoga, we
Definitely
are
we'll
having
do.
4 colposcopy workshops, and the next week, that is on
Okay.
27th and 28th, we are doing consecutively in Bagalkot and Dharwad. And I
Okay.
request that if any members who are interested from the societies, take up this program of colposcopy workshop in the screening so that we can intensify. Our goal is to do one workshop in each zone. So now we have in Bagalkot and Dharwad, and then we would like to go to the south and the southwest zone and conduct such workshops so that there is equal dissemination of the kind of knowledge and the impact that we want to create on the societies. And as much as we talk about the cancer screening, it is even less, because how much ever we motivate the patient, the acceptance level in our country is still low. And just for the fact that there is no screening and no acceptance, we are losing many patients to this cancer. And as rightly visualized, and the far sight program that we all thought of, like, if some country like Australia could eliminate, why not India, when we can intensify our measures so much so? Thank you very much, Dr. Sundari. We'll connect again for doing some nice workshops on, having such programs of ablative therapy and such. Dr. Rupesh, I think, will coordinate and do some programs further.
Definitely, ma'am. Thank you so much,
Sure, Dr.
and
Thank you.
Rajesh. It's my
very, very
pleasure and
reassuring
my
from your
honor.
side,
Okay. Anytime.
madam.
Unfortunately, I'm here abroad now. I'll be soon coming back to our place. Anytime you want me anywhere, I'll come and whatever best I could do, I'll do for this. This is my
Definitely, ma'am.
goal of my life is this.
Definitely, we will not leave you, madam. We will definitely
And
Thank you.
take your
Thank you very
services,
much.
because whatever you've presented today is not simply just a talk
yes,
for a webinar.
yes,
It is something which is a calling, especially for every listener and who will
yes,
definitely listen to this video again. Also, it's
very
not
true.
just a presentation. It's something which is so. As Rajshri madam so aptly pointed out, the actual practical issue that the fear that exists in the rural community. I mean, in terms of the doctors also, when the patient comes lost for follow up, is one of the biggest concerns. Hysterectomy ಅನ್ನೋದು ಎಷ್ಟು ನಮ್ಮ ತಲೆನಲ್ಲಿ ಕೂತಿರುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ, but after your talk I'm sure that people will start like starting believing in that. ಇಲ್ಲ
We can do that.
Yes,
And
ma'am.
we can have protocol for
very
our
very
own
wonderful
Karnataka
presentation,
in
and
your
without
tenure,
wasting much.
Rajeshri.
Yes.
what we need to do for all this and how do we go about. You can have protocols and we can spread it out throughout Karnataka, and
Yes,
then we
yes.
can start doing
Definitely, ma'am.
it.
We need to
Yeah, we
intensify
have a
this,
plan,
madam.
madam.
Let us
We
take
have
this
a
as small things done at small intervals is what is needed. We don't
Yes,
have to
see,
talk
with
big and do
our
big.
own facilities, what we have,
Yes.
what test we can do, how do we try to reach the goal of elimination in Karnataka? We can
Absolutely.
form a protocol for ourselves and percolate it down to the towns level, even the PHC levels.
Yes.
definitely, ma'am. We have a
Like
plan
that,
of
we have to do.
starting a steering committee ತರ ಒಂದು plan ಇದೆ, madam. Rajshri madam is so aggressive and so active that ನಮ್ಮನ್ನ
Yeah, yeah.
ಸಖತ್ ಇನ್ಸ್ಪೈರ್ ಮಾಡ್ತಾರೆ.
We can
Chairperson
do
ಆಗಿ
that.
definitely last year also Durga Das was very nice, and Rajshri madam is like so much that we ಇನ್ನೂ ಏನೋ ಮಾಡ್ಬೇಕು ಅಂತ ಅನ್ಸೋಂಗ್ ಮಾಡ್ತಾರೆ. So definitely we'll one steering committee or something like that. We have
Sure.
some plans, and
Sure, Dr.
we
See,
have given
one
the
goal we
year
keep your
year of
tenures and
these
then we'll try to
ಕೊಟ್ಟಿದ್ದೀವಿ.
finish so that others can take
See,
it forward.
considering the 90-70-90 goal, one aspect that we are doing is, sensitizing towards the vaccination and all. So when we go a step ahead and do towards the screening process, then definitely and aptly you have chosen topics for today. You know, that now we are moving ahead to the radiotherapy, which Dr. Vinay Babu will tell us. That means to intensify the management aspects. So I think we'll all, Rupesh sir, will connect again on this and take a project so that we can, do some workshops for CIN and pre-invasive lesions. Okay. Thank you.
Definitely,
Sir.
ma'am. So over
Thank
to
you.
Dr. Vinay Babu
Yes.
for his much-awaited presentation. I'm so sorry, Dr. Vinay, that you had to wait for a little extra
No,
time.
no, no, not at all, sir.
But we had such wonderful talks, Andre, for gynecologists. Those are the most important things.
I
I'm sure that
completely
now
agree,
whatever
sorry.
you're going to talk, yeah, and whatever you name Nimma Ivaga, whatever you talk will be something which is gonna kind of fix everybody, and all of us will be very confident about managing cervical cancer. Dr. Vinay Babu has done his MD in radiation oncology from the prestigious Madras Medical College, Chennai in 2012, and then moved on to PD Hinduja Hospital, Mumbai for further experience. I've been very, Dr. Vinay has been a good friend because when I was doing my PG, he was in MS Ramia doing his undergrad, and I'm sure that Sundari madam will be doubly happy and proud that two of our students are today in this webinar. He also later has wonderful. Places, I mean, opportunities of working in places like Tata Memorial Hospital, Mumbai, and TMC Kolkata also. Vast experience of 13 years in radiation oncology. His experience and his areas of interest are genitourinary, gynae cancers, brain and breast cancers as well. Without wasting much of time, Dr. Vinay, we are waiting for your talk. Please go ahead and enlighten us. Thank you so much.
Thank you for your
Dr.
kind words, sir.
Vinay, very proud of you.
Thank you, ma'am. It's a pleasure to meet you. Yeah, thank you. So, am I
So
audible?
nice.
Yes, you are, please. You are,
What
please.
about my slides? Are my slides visible?
Perfect.
Yes, sir. Yeah. So, good evening, everyone. I would like to thank Kasoga and Dr. Rupesh sir for giving me this opportunity to speak about the role of radiotherapy in the management of locally advanced cervical cancer. So before going into my presentation, I would like you to just recall the 5-year overall survival. When you look at the stage 1, it is around 90 to 95%. And stage 2, it is around anywhere between 65% to 70%. Stage 3, around 30%. And stage 4, around 20%. So, and what is important here is you look at this stage 1B2 in figure 9, 2009 and 1B3 in figure 2018. Once the tumor size grows more than 4 centimeter, the 5-year survival significantly drops. Here you can see it's 70 to 75 once it is more than 4 centimeter. So these are the recent changes which happened in figure 2018. One is stage 1B. It is further divided into 1B1, B2, B3 based on the tumor size. That is B1 is less than 2, B2 is 2 to 4 centimeter, B3 is more than 4 centimeter. And in this new classification, even pelvic nodal and nodal involvement is also accounted for. And stage 3 is added into the new figure staging. C1 is pelvic lymph nodal mets and C2 is para-aortic nodal mets. So traditionally, stage 2B to stage 4A is considered as locally advanced cervical cancer, and stage 1A to 2A2. sorry, stage 1A1 to stage 2A2 is considered early stage. But many oncologists include stage 1B and selectively 2A1 and 2A2 into locally advanced cervical cancer. So now coming to this locally advanced stage 1B2. So what are the treatment modalities we have? We have both surgery and radiation. Both surgery and radiation are equally cured this stage 1B and 2. But however, there has been a still ongoing debate regarding the optimal treatment, whether surgery has to be opted or radiation. So this is the only prospective trial in this locally advanced 1B2A group of patients where they compare surgery versus EBRT and post-surgery. These people were treated with post-operative radiotherapy if they had parametrial involvement, closed margin, or positive surgical margin, or lymph nodal involvement. So now look at this survival. At 5-year survival, there was no difference between radiation or surgery. And even in the updated study, updated in 2027, and the 20-year survival, again, there is no significant difference between surgery and radiation. However, nearly 2/3 of these patients had received adjuvant radiation, that is post-operative radiotherapy post-surgery. So because of that, you see here, the outcomes may be, survival outcomes may be similar, but the toxicities are significantly increased in a combined modality of the treatment. That is nearly double compared to radiation alone. You can see here 30% in the radiation alone arm, and it is nearly close to 60% in combined modality arm. So what did we learn from this prospective trial? So as complications are highest in this group of patients, especially combined modality treatment, patients should be appropriately selected for surgery. That is, they must have a very low likelihood of requiring post-op radiotherapy in order to reduce complications. So what are the risk factors post-surgery? So post-operative treatment is needed based on the risk factors. So we generally divide into intermediate risk and high risk. Intermediate risk basically involves these three factors: lymphovascular space invasion, or if size more than 4 centimeter, and stromal invasion more than 1/3. If any of these two tumors are there, these two factors are present in the histopathology, post-operative radiotherapy is recommended for this intermediate risk group. In high risk group, these three P's are considered as high risk. If any one of these is present in histopathology, chemo is added along with the radiation in the post-op setting, either post-operative margin, post-operative parametrium, or positive lymph nodes. So one of these factors is sufficient for chemo radiation. So this is the decision tree, that is before the pre-treatment evaluation. So what we also at our institute, we follow this decision tree. So based on the clinical examination, if patient has a size of more than 4 centimeter and parametrial involvement, this patient will automatically go to radiation. And on PET-CT imaging, if lymph nodes are positive, again, these patients will go to radiation. And most importantly, I want you to bring to this specific aspect. On diagnostic MRI, if we see deep myometrial invasion, and if size is close to 4 centimeter, we consider radiation rather than surgery. And if all these factors are negative, then these patients are taken up for surgery. So beyond 2B, radiation is preferred over surgery. But these 5 trials demonstrated improved survival with chemoradiation compared to radiation alone. You can see here, these randomized control trials demonstrated at least 10 to 15% of survival advantage at 15 years. So based on these trials, NCI issued an alert recommending EBRT with concurrent cisplatin in 1999. And the subsequent meta-analysis of 18 randomized trials endorsed this recommendation of NCI, as there was a significant benefit with chemotherapy, that is close to 6% overall survival benefit. So this benefit was seen across all the stages, though the benefit was maximum in early stage, that is stage 1 to 2A, nearly 10%, stage 2B around 7%, and it was low in advanced stages, it is hardly 3% benefit. So to improve the outcomes better than chemoradiation, multiple strategies have been tried. One of the strategy is neoadjuvant chemotherapy before surgery. Presently, there is no consensus as to whether NACT improves prognosis compared to standard treatment. There has been two randomized control trials. One is EORTC and one is Gupta et al. From TMH Mumbai. EORTC showed no difference in the 5-year survival, but there was an increased toxicity in the neoadjuvant arm. And Gupta et al. Showed superior DFS in chemoradiotherapy arm. So the recent ESGO and ESTRO guidelines did not recommend, it doesn't recommend neoadjuvant chemotherapy before surgery outside of clinical trials. And the second strategy is consolidation chemotherapy, that is addition of chemotherapy post standard chemoradiation. So they compared additional chemotherapy with standard chemoradiation. Again, this arm had a significant toxicity. However, there was no improvement in the survival. Coming to the third strategy, here they have used additional chemotherapy prior to standard chemotherapy. This is the standard arm chemoradiotherapy. Here, prior to standard arm, they have added additional chemotherapy, that is carboplatin and paclitaxel for nearly week 1 to week 6. And they have shown significant improvement in the 5-year overall survival, 80%. The 5-year survival was 80% versus 72%. However, there has been a lot of criticism on this trial because many of these patients had significant hematological toxicities, and many of these patients could not undergo or finish 5 cycles of chemotherapy during chemotherapy. And also the survival shown in the standard arm is inferior to the present chemoradiotherapy arm. And the fourth strategy is adding immunotherapy along with the standard chemoradiotherapy. So one arm is immunotherapy plus standard chemoradiotherapy versus chemoradiotherapy. There has been an improved 2-year progression-free survival with immunotherapy compared to placebo. However, we need to wait for the long-term results. I am not going into details of the stage 4B or distant metastasis. However, chemotherapy is the mainstay of the treatment. Platinum doublet is the standard chemotherapy. However, if patient is fit, we may add bevacizumab or immunotherapy along with chemotherapy. Coming to RT planning, the recommended dose for the CS cervix, advanced CS cervix, is 45 to 50 Gray to the microscopic disease and close to 85 to 90 Gray to the gross disease. So initial part of the treatment, that is external beam radiotherapy, we give 45 Gray in 25 fraction to the entire pelvis, and additional 10 Gray, that is 55 Gray in 25 fractions, is delivered to the enlarged pelvic node. Along with this external radiation, we add concurrent cisplatin 40 mg per meter square once a week for 5 weeks. So this is the conventional treatment. You must have seen these patients with the markings over the body. In conventional treatment, we create a field, treatment field based on the surface anatomy, and we place metal wires around the edges of the fields. And these patients are taken in the X-ray and confirm whether the treatment fields is adequate. I don't know whether you'll be able to appreciate the metal wires here. So based on this, we either increase the field or reduce the field based on the X-ray. So this is the pelvic field, and what you are seeing here is para-aortic field. In the advanced technique, that is in IMRT, we acquire planning CT scan, and MRI is fused onto the CT scan, and then we start marking the tumor and also the high risk areas like uterus, parametrium, vagina, and lymph nodal region. We also mark the normal structures like bladder, rectum, and bowel. So I don't know whether I'll be able to play this or not. Let me check. Yeah, you can see here, this is the planning scan which we have taken, and this is the wall. What you are seeing in red is the treatment plan, our contouring of high risk area, lymph nodal region, uterus, parametrium, and vagina. So this, we are going to mark out all these areas. So now this is the techniques about the conventional technique and advanced IMRT technique. In conventional technique, you can see here, we mainly use 4 fields. It's also called box field technique, where you see the 45 gray or 50 gray uniform dose, not only to the tumor, but also to the surrounding normal structures. You can see a significant portion of the bladder getting the full dose, and entire rectum is getting full dose, and even the bilateral hip joint is getting full doses. However, you see here we use multiple fields of varying intensity to deliver the dose only to the tumor and high-risk areas like parametrium and lymph nodal region. At the same time, we spare bladder and other important normal tissues, in this case, rectum and bladder. Coming to EFRT, that is extended field RT. Extended field RT is delivered only in the presence of positive paralytic lymph nodes, or according to this ESGO-ESTRO 2023 guidelines, presently there is no role of EFRT if patient has negative paralytic or negative common iliac lymph nodes. Prophylactic EFRT is recommended only for the documented common iliac lymph nodes. So post EBRT, that is post TeleRT, post 45 gray, we won't be able to further deliver using external radiation because of the tolerance of the normal tissue. So what we are going to do is, we are going to escalate the dose up to 90 gray through a brachytherapy, either intracavitary or interstitial brachytherapy. What you are seeing is intracavitary brachytherapy. Here is the intracavitary applicator. The tandem is inserted into the uterine canal, and the ovoid, the ring, is placed at the external os into the vaginal cavity. And by placing this applicator, we will be able to deliver only to the cervix, avoiding radiation to the surrounding structures. So you can appreciate here, the dose is restricted to the cervix and hardly any dose to the rectum and bladder. So that's how we will be able to escalate the dose to tumor alone. So I'm going to skip this slide. This is basically a 0.8 dose. This is where we prescribe a dose using intracavitary application. But this intracavitary application is possible if tumor is less than 4 centimeter. If more than 4 centimeter, we won't be able to use intracavitary application. In those situations, we use interstitial brachytherapy. So interstitial brachytherapy is nothing but inserting multiple needles or catheters into the primary tumor and also the parametrium through the perineal template. So this technique is utilized only when intracavitary application is not possible. Say suppose poor response after EBRT, still the residual disease of more than 4 centimeter, residual disease in the parametrium, unable to sound the uterus, or narrow vagina where you cannot insert the application. In those situations, we prefer interstitial than intracavitary brachytherapy. Coming to long-term complications, among GI complications, the common complications are bowel adhesions, obstructions, strictures, fistula, and bleeding. Proctitis is one of the commonest late complications, which we see in nearly 10% of our patients. Coming to GU complications, frequency, urgency, bleeding, and chronic cystitis is again the common complication. We may see in nearly 5% of the patients. Sexual dysfunction, it is common in nearly 90 to 100% of the patient. Basically, vaginal dryness, fibrosis, and vaginal stenosis. Ovarian dysfunction, again, it's common in almost every patient. Osteitis of the bone, that is brittle bone or fracture of the bone, is common, but it's 1/3 of the patients are less. And the last but not least, second malignancy. Again, it is 1% at 10 years. It's very rare, but it is still no 1% at 10 years. The most important is vaginal dilator. This is the most important component post-treatment care, not only to prevent the vaginal stenosis and also for the physical examination and the surveillance. So it is recommended to use at least 2 to 3 times per week for at least 2 years. And we also encourage patients to engage in sexual activity to prevent vaginal stenosis. So to conclude, definitive RT or chemoradiation is a preferred in patients likely to require post-operative RT, avoiding treatment-related morbidity. And technological advancements will lead to better dose escalation and sparing of normal tissues. IMRT seems to be promising due to dosimetric superiority and also clinical benefit with in terms of immediate and late effects. Image-guided brachytherapy can improve outcomes in patients with locally advanced CS cervix. Interlace regimen, that is neoadjuvant chemotherapy prior to standard chemoradiation, can be considered when there may be a delay in initiation of radiotherapy. And vaginal dilators should be encouraged in all women who receive radiotherapy for intact cervical cancer, independent of sexual activity. Thank you for your patient attention. Thank you.
Dr. Vinay, thank you so much. Actually, like radiation, the topic of radiation in cervical cancer, even though it is so kind of common and if it is so, uh, how do you say, a very accepted kind of a thing for the gynecologists or for the surgeons, I mean, gynecological oncosurgeons or for any community as such. Uh, you have so beautifully highlighted the importance of each one of us to know, especially when you spoke about the uh, this long-term complications and all. The gynecologists, when they are referring the patients to radiation, for example, they have examined and they know that okay, this is stage 2B or this is stage 3B or whatever it is, and they have straight away referred to the person to the radiation oncologist in the nearest vicinity. Now they will be in a good zone to understand when the patient comes back to them, especially whenever there's proctitis or whenever there's cystitis or when there's sexual dysfunction. Like today, we are seeing a lot of young women with cancers as well. So each one of them is, I'm sure that today there's a lot of message that has gone to our gynecologists that what they have to expect. And of course, your additional talk about the image guided therapy is something which is very important for the gynecologists because many of our centers in India still radiation still have the 3D conformal radiation therapies. But whenever there is a facility for image guided radiation, either IMRT or IGRT or whatever it is, definitely those patients who are affordable and gynecologists can always talk to their radiation oncologist and do. So my definitely my main intention of this entire webinar was to, or rather, every single webinar that I do for Kasoga has always been to empower our gynecologists with regards to the gynecological malignancies. And today, I am extremely thankful to all my wonderful speakers who have made their mark, who have, actually made their presence so beautifully felt that, right from the screening aspects, what Dr. Veena spoke, and right from the management of the pre-invasive lesions, what Sundari Madam spoke, and right from the locally advanced cervical cancer, what yourself you spoke. I'm sure that of course, there's one topic which I left behind, which is the
Fertility management.
surgical aspect, the surgical aspect for the early cervical cancers. But that is something again which was out of the bounds for this particular webinar. So, but I honestly, from the bottom of my heart, I
Can
thank
I
you so much
can I
for
say
having
something,
celebrate.
Rupesh?
Yeah, please, 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 madam, please, madam.
Dr. Veena, it was a fantastic talk. I wish more postgraduates could have logged in. They would have really learned a lot. They needn't look at any chapter, any book after listening to your presentation. It was a complete, because most of the cervical cancers present in late stages. This is what they're going to go
Correct.
through actually. It was a great talk. I really enjoyed. And Sundari ma'am, it
Thank you.
was
Thank you.
fantastic listening to you again. Thank you so much for the opportunity, Dr. Rupesh. Thank you so much.
Thank you. Thank you. Thank you so much, all of you. You have not just, kind of did the best what you could deliberate, but you have elevated the entire, the basic, the basic intent of this webinar. I'm thankful to all of you. And I'm sure that many of the, our today's speakers, I think Rajshri Madam had messaged that she had to leave. I would have loved to have Rajshri Madam's address at the end of this. I'm sure she would be very proud of this webinar. I am, of course. And if I could conclude the remarks for this webinar, it was one of the very, very important. And as I said, there are a lot of subtle topics, and they are very upcoming topics, and the existing conventional topics, which have been covered with really vast expertise and a lot of data as well as research evidences that each one of you have produced. Be it Dr. Veena, be it Dr. Sundri, but be it Dr. Vinay, all of you, thank you so much from the bottom of my heart. And thank you so much, Dr. Rajshri Madam, Dr. Shubha Madam, and Dr. Shubha Bembalgi Madam, who are the pillars of the Kasoga. And of course, our patrons, Dr. Nagraj Sir, everybody, that you have given us the opportunity and the platform today that we have been able to deliberate all these things. I hope that the recording will be going down to many of the gynecologists who are very inclined towards and who see a lot of such cases. And yeah, who will be definitely now more informative and well informed about how to handle these cases down the line further. I'm sure that will be the case. Thank you so much, each one of you. Madam, is there? I think Rajni Madam has left. I'm so sorry. Shobha Madam, Shobha Gudi Madam, are you there? Because Shobha Gudi Madam is always one of those people who so beautifully summarizes things, and she's the one who actually very beautifully gives even the word of thanks as well. But I'm sorry that she isn't there. Anyways, thank you so much, Dr. Veena, Dr. Vinay. I don't know. I'm very indebted to you. Anytime, if you call me for anything, if I can offer, I would be more than happy. That is how I can reciprocate to you at this moment. But thank you so much. It was a wonderful, wonderful webinar. I'm sure many of us would be very enlightened to change our practice or like improvise ourselves to give the best to our patients. Thank you so much and have a great night. Thank you so much, Dr.